Dr. Joe Watso, I want to talk blood pressure. This is really your area of expertise. Much of your research is in this realm. But a lot of times things are lacking in terms of what people put out on the internet as actionable ways to really lower blood pressure. People might just talk about the general things like, okay, yeah, exercise and good diet. And although that's wonderful, it doesn't really give us actionable steps. And as someone that's in the lab looking at this stuff day in and day out, like, what can we do? Like, what are some actionable things?
Yeah, so there's a few things you could do that are modifiable, and we can even get a little bit deeper. Obviously, diet and exercise do have a role, but even within diet, a lot of times there's, it's a whole black box when you say good diet or healthy diet. But specific to blood pressure, a few of the things you could do related to adopting it's called the DASH, or the dietary approaches to stop hypertension. And from that framework, there's a few things that are you can include into any basically diet framework. One is reducing sodium intake. Another is increasing potassium intake. And I can talk a little bit about what foods might have more or less of those things. And also having relatively low-fat dairy and low saturated fat as well. So those are some of the main things that are associated with generally having a lower blood pressure.
What about in the terms of more unconventional things that people aren't really thinking about, like not necessarily diet?
Yeah, so there's some pretty interesting emerging things going on, some of which we're studying in the laboratory. One example is isometric exercise training. And a year or two ago, there was a big meta-analysis that actually split up every single exercise modality. So that is walking, running, cycling, isometric wall squat, cycling exercise, all those modalities. And actually all the isometric exercise training studies turned out to have the largest reductions in blood pressure, which was pretty surprising. And one of those that we're studying in the lab is isometric hand grip training. There's some, that's a pretty approachable way to do it because the devices are like $20 on Amazon. If you just Google isometric hand grip trainer, you can get one and then just look at the protocols that might be available in those studies. The other one is a wall squat or leg extension. Leg extension is tricky because then you need equipment. And then the wall squat can be a little bit difficult to gauge, which I can talk more about. But
why would an isometric be more powerful than like traditional exercise?
Yeah, so I guess for powerful, I want to be specific to blood pressure alone. Just like a good diet, it's going to have some variability. Eat the rainbow. And for exercise, you probably want to do that as well. But for isometric, I think part of it probably is due to, one, the novelty, honestly, and that's not really something that people will do. So if you're doing a wall sit for 2 minutes, that's usually not something that people are doing very often. As far as mechanisms, what's actually happening when you're doing that exercise that's isometric, you're driving blood pressure up quite high, but it's in a way that's static. So I think some of those changes with increasing pressure and increasing shear stress in the blood vessels, so that is the blood flowing and pushing up against the artery wall and the inner lining, the endothelial layer, some of those lead to adaptations that are favorable for blood pressure and vascular function.
I mean, we're starting to see some evidence with isometrics and hypertrophy too. So I think there's a whole new world that's going to open up pretty soon. Anyone that's ever done real isometrics, it's not easy. Yeah. So it's not like you're just, flexing a muscle. And I mean, that's taxing.
It's fatiguing. Yeah. The last 30 seconds, if you're doing a 2-minute isometric hand grip hold, the last 30 seconds should feel like you can't quite feel your hand. And then you switch and do it again. So you do right hand, left hand, right hand, left hand, or left, right, left, right.
So, outside of the isometric type exercise, what are some other things that we've seen that can modulate blood pressure?
I put a link down below for 30% off your entire first order with Thrive Market. Thrive Market focuses on the ingredient quality. That's why getting 30% off your first order with them is awesome. If you go to the grocery store, the reality is you have to spend a lot of time and you need a practical PhD to really read the ingredients, to really understand and cross-reference it. Thrive Market does that already. They do not have garbage ingredients coming into the food that they have on their digital shelves, so to speak. So the reason that I trust Thrive Market is because I know that even if I'm getting something that's like a sweet treat or something that I want to enjoy that's even a snack, at least I don't have to worry about having low quality ingredients. And you can sort by different diet type. I spent a lot of time in Europe recently and I was just almost in love with the food quality there. And the thing that I like about Thrive is they do a good job of emulating the kind of food quality that's coming into the foods that they have. So that link down below gets you 30% off. It gets delivered right to your doorstep, and you get a free $60 gift with any purchase. So go ahead and check them out. It's in the top line of the description underneath this video.
Yeah, so I guess going back to the framework of diet and exercise, just to mention if there's anything I missed there. So we mentioned sodium, potassium, low fat, low saturated fat, and then the isometric exercise. One thing that's emerging that's really interesting for us is inspiratory muscle training. So I actually brought a trainer with me today. It's from Power Breathe. I have no affiliation or anything with the company, but we do employ them in our National Institutes of Health funded research right now. And there's a pretty strong literature behind it with blood pressure reduction. And for numbers, in healthy young adults, even college-age people that don't have high blood pressure, it's reducing blood pressure by 4, 5, or 6 millimeters of mercury, which is right on the cusp of what people consider a clinically relevant change in blood pressure for an individual. And there's studies that have employed this training to along the spectrum of older people with obstructive sleep apnea, and they've had blood pressure reductions in the 12 to 15 millimeters of mercury range just from doing the training, which I can talk more about, but it only takes about 5 to 10 minutes a day, which honestly is sort of too good to be true. But there is now 5 or 6 independent trials in different populations conducting at least 2 or 3 different sites that have found a similar thing. And some of our pilot data coincide with that, with about a 5 to 7% reduction in systolic blood pressure, which is pretty remarkable, honestly.
How does that compare to like some of the blood pressure medications that are out there?
Yeah, so obviously it varies by dose and how many medications you're on, but from what I've read, somewhere in the range of 5 to 10 millimeters of mercury is generally considered to be a pretty good response, depending on where you start off with. And obviously the more medications you add and the higher doses you get, and you get resistance to certain medications for certain people. So you basically get things that are in line with sort of first-line antihypertensive therapy with medications with some of these modalities that are non-pharmacological. Obviously, there is a little bit of risk involved, but generally exercise is recommended as pretty safe for most people. What's
the potential mechanism here? Like, why do you think that just training these breathing muscles is helping out with blood pressure?
Yeah, there's a few different avenues. One is that it could be driving the parasympathetic nervous system. So if you think about your breathing and doing diaphragmatic breathing, there's a link there between how you breathe and your autonomic nervous system. So that could be one benefit or one change that's leading to that benefit. Number 2 is that there's a lot of shear stress that's occurring. So that's blood flowing against the inner lining of the artery, the endothelial layer. And there are studies finding that in one of those trials, for example, that found a reduction in blood pressure. This one was in people that were middle-aged to older adults with above normal blood pressure. They also had improved endothelial function with this training after 6 weeks. And a third hypothesis is that if you think about where that shear stress is occurring, from all that breathing, you're obviously having a lot of blood flow going up and down the thoracic area and the neck. And right in your neck are your baroreceptors. So those are special sensors in the body that detect blood pressure changes. And basically how elastic they are can impact how your blood pressure is regulated. So it could be that specifically having adaptation at that vascular site could also influence the way that your body senses blood pressure. And that's one where there's a little bit less known, and that's more of the speculation about things that might be occurring. And all of those things that I mentioned, we are looking at in the lab, but our results are too preliminary right now.
That's pretty wild. That's I want to double click a little bit on like endothelial health in the first place, because I feel like that's maybe an area that people don't always understand, at least just casual consumers on YouTube. You know, they're not understanding that maybe the blood vessels have sort of a, you know, they're alive, so to speak, right? Like they're not just this tube. And that brings me to questions even surrounding like nitric oxide and things like that. Like how relevant are things like that we potentially add into the diet? Like we've heard, like, you know, having beet juice, things like that can be really good for nitric oxide production, and that can be good for blood pressure. From what you've seen, is there merit there? Can it influence it in a positive way, or is it pretty negligible?
As far as the inspiratory muscle training?
Well, no, even if we pivot from that for a minute,
So
just in terms of just even coming back to diet.
Just health. Yeah. Okay, so one thing to think about is that for cardiac function, your heart needs to work, right? So your heart needs to pump and requires oxygen. And the blood vessels supply oxygen to the heart. And if there's a blockage there, or you have poor vessel function then that's going to be problematic. So what we do in the lab is, obviously it's difficult to assess the blood vessels of the heart without being too invasive, but we can measure similarly sized arteries in the limb. So for example, in the upper arm, the brachial artery is very accessible. So what we do is we use non-invasive ultrasound to measure endothelial function using a variety of tests. And endothelial function is largely dependent on nitric oxide, among other things. And that has a role for blood pressure because people with high blood pressure typically have lower endothelial function, and the reverse is also true. And one example of this would be Doug Seal's lab out in Boulder, Colorado. I think it was 2 or 3 years ago. They published a paper showing that between people with hypertension, it was when the new guidelines were released. So there was stage 2 hypertension, stage 1 elevated blood pressure, and normal blood pressure. And there's a dose-dependent change in endothelial function assessed by flow media dilation. So those with the lowest blood pressure had the highest endothelial function. So it definitely is linked to cardiovascular health and blood pressure, which is the key modifiable risk factor for cardiovascular disease, which is the leading cause of death in the world.
How does, if we can talk about the basics of NO2 and how that kind of works, like how does that influence blood pressure and endothelial health? Like what's actually going on just at the very basic level?
Yeah, so good question. Basically what happens is through a cascade of events at the molecular level, nitric oxide promotes the smooth muscle that controls the tone of the vessel to relax. So more nitric oxide will relax the smooth muscle and allow the vessel to relax or dilate. And when you have something dilate or relax, then the pressure in that tube will go down. So that's sort of the direct relation between the two in simple terms.
Interesting. Is there ever a state where NO2 gets too high, and what does that typically like indicate?
I'm not aware of NO getting too high. For context, there's you mentioned beetroot juice, which provides dietary nitrate, which is through the oral microbiome working down to nitrite. So you consume dietary nitrate, breaks down to nitrate, and then eventually nitric oxide. And there are studies where they've had people consume 4 times the dose of what's recommended for performance benefits of nitric oxide. And I don't believe that there is any detrimental effects of that for nitric oxide in the context of cardiovascular function in a short-term study at least. So I'm not aware of anything that too much nitric oxide is problematic, because if you think about the vessel can only relax so much and it has some structural integrity. So obviously it's not just going to continually relax. At some point it'll just have there's tissues around it, so it'll have to stop relaxing at some point. Would you say
is the juice worth the squeeze, so to speak, for someone that's trying to lower blood pressure to consume something like beets or beet juice?
I think so. I personally do consume beetroot juice every morning. The dose that I found from the literature that seems to be most effective, bang for your buck, is 5 millimolar. And what that translates to is about 1 Beetroot shot. So Beetroot is a company I have no affiliation with or anything. But each of their, they call them shots, they're little containers. They have about that much. And if you want this at your grocery store and you don't want to order from Beetroot, because they tend to be at least $1, and they're probably closer to $2 or $3 per shot, which could be pretty costly. But beetroot juice at your store would be fine. They're in a lot of grocery stores. I personally use liquid organic beetroot juice because there is a large study done maybe 5 to 10 years ago now, so maybe there should be a newer one that I should look at. But as far as I know, the only study that actually partitioned out all the different supplements or drinks that include, or juices that include beet juice, and they looked at the bioavailability of nitrate, and that one turned out to be pretty good. And if you consume, I don't know the exact amounts, but 4 to 5 ounces-ish per day, for most people it'll work out to about $1 a day, which is more than or less than half the cost of what the Beetroot shots would cost.
Dang, that's pretty awesome. I mean, I personally notice a pretty big improvement maybe not a big improvement in performance, but at least perceived, it feels a lot better if I train and I have some beet juice, or, obviously people take supplements that increase that all the time, but it's usually combined with other things that are also vasoconstrictors, so probably cancel it out a little bit.
Yeah, but the multifaceted nature of nitric oxide is beneficial. So even if you don't care about a performance benefit, you might get one. And if you're taking it for performance, you might get a cardiovascular health benefit, even if you're not asking for it. So as far as the safety profile, assuming you don't have symptoms related to low blood pressure or fainting or anything like that, maybe you talk to your doctor about that first. But assuming you have normal blood pressure regulation, then it's probably going to be generally beneficial for most people.
What about the potential negative impact of caffeine on blood pressure? Is it worth being concerned about, or is it something where it's so short-lived and it's not, I mean, it's as a vasoconstrictor?
Yeah, so there's probably too much variability for me to really provide too much concrete advice. I think that if I'm recalling correctly, I think what I've seen more often is that if you're caffeine naive and you have caffeine, that could increase blood pressure, and just other things that are related to blood pressure reactivity, which is how much blood pressure changes given a given stimulus, will increase. So things like aging, for example. So older adults seem to be, there's at least one study that had older adults consume caffeine, and especially in the older males, they tended to have a larger increase in blood pressure than the younger adults or even the older females. But I don't recall the caffeine status of those people. So that's been on the short list of the studies that we've wanted to do for a while. We just haven't quite gotten to it yet.
Yeah. I mean, my hunch would be, I mean, for a lot of people, if the caffeine is what gets them active, then it's like you got to look at that trade-off, right?
Right.
It's like if some people, well, I mean, realistically, it probably wouldn't take long to not need the caffeine, but if the caffeine is what gives you the spark to go for a walk or go be active, then it's probably a net positive. But it all depends on if you're taking in 700 milligrams a day or not.
Right.
So, what are some of the other things that you've seen in your lab? I mean, you're doing some work right now, surrounding this. What are some other things that you've seen that, independent of blood pressure medications to modulate blood pressure?
Yes, we talked a little about diet and sort of traditional forms of exercise. So things like aerobic exercise, for example, for people without hypertension, will probably reduce blood pressure in the range of 2, 3, or 4 millimeters of mercury. If you have hypertension, it's a range, but maybe close to that 5 to 8 millimeters of mercury reduction. And kind of a similar story for the salt restriction or the sodium restriction and increasing potassium. Pulling on both of those levers has relatively similar impacts on blood pressure between populations. But I think that aside from the respiratory muscle training are sort of the key things that we study. Obviously, there's a whole domain that I'm sort of ignoring here, and that's just because I don't have training in that. That is the psychological aspect. So that is the symptoms of depression, anxiety, mental health, well-being, emotional status, or emotional health and well-being. Obviously, all those things can have a lot of influence. But I think there's a lot of things, unfortunately, there's a lot of things that can make blood pressure go up, and there's probably fewer things that can help it go down. So I'll give you an example, like getting a bad night of sleep, being stressed. Those are easy ways for your blood pressure to increase at rest, but you have only so many tools to reduce blood pressure from a non-pharmacological point of view.
Yeah. Now the guidelines or sort of the recommended blood pressure ranges have changed over the last 15 years, right? They've
in 2017.
Okay. Yeah. What was the driver for that change, and what are they now versus what were they before?
Yeah. So it used to be that hypertension was a blood pressure of 140 over 90. So the top number systolic, bottom number diastolic. And I think pre-hypertension was sort of in the middle ground between that and 120 over 80, which has, as far as I know, always been the optimal or normal blood pressure threshold. So you want to be below 120 and 80. And in 2017, the American College of Cardiology, American Heart Association, and a whole battery of other acronym organizations came together, and the new consensus was that basically they wanted people to get lower resting blood pressure than those previous treatment targets, because there's still a lot of benefit that's left on the table when you treat to 130 over 90. So in other words, if you treat to 120 over 80, you get better health outcomes related to the cardiovascular system and even all-cause mortality. And I don't think there's quite as much data on it, but I still think that there's a pretty strong case for even lower is better, obviously to some point. I'll give an example. So 110 over 70 is probably better than 120 over 80. Mm-hmm. And as far as the threshold for too low, there's a lot of numbers thrown around, maybe 90 over 50, but In that sense, you just want to make sure that your blood pressure is adequate to respond to stress of daily living. For example, if you stand up too quickly and your blood pressure is already quite low, then you could have orthostatic intolerance, and then you could have things like fainting. So you don't want to be down on that spectrum. But in my mind, I would think that a blood pressure of 100/60 plus or minus 5 millimeters of mercury is probably sort of in the optimal range.
Yeah.
Even better than 120/80.
What about, if we go the other way for a minute, people that have lower blood pressure issues, it's like, are those people that should add more salt to their diet? Like and is there usually a genetic predisposition for that, or is there a health related concern with that? What's the deal with lower blood pressure?
Yeah. So if you have orthostatic intolerance, so there is a linkage, obviously. People with lower resting blood pressure tend to be also those that are at risk for orthostatic intolerance. The example would be premenopausal females. Generally have lower blood pressure related to estrogen, other sex hormones, and a variety of other factors. And they tend to be the most prone to fainting and orthostatic hypotension. So that is like fainting upon standing from a seated or supine posture. And salt consumption is a beneficial way to help them maintain or regulate, to make sure that they have enough blood volume and that they can regulate blood pressure when they do have those sort of stresses of daily living, for example. But in most cases, if your blood pressure is north of 100/60, then I would not probably preemptively recommend that you dramatically increase your salt intake, if that was your concern, if you've never had really any of those fainting episodes or symptoms.
Yeah. What is it just, it might be a very basic question, but it's probably worth talking about. Is it simply just a blood volume thing? With sodium, you're just kind of just creating too much overall volume?
Yeah, so there's a whole can of worms here with sodium, so we can go as deep as you'd like. But one, as you point out, immediate impact is just increasing blood volume. So if you have more solute in anything, that'll cause plasma volume expansion. Specifically, sodium tends to be the most osmotically active. So that is, it'll be a large driver of increasing volume. Salt also has other effects that contribute to increasing blood pressure. There's obviously variability, and there's this idea of salt sensitivity and salt resistance. So that is, does your blood pressure at rest change when you have a higher low salt diet? But independent of that, there's still other things that salt causes that can still drive blood pressure over time. So one example would be, even if your resting blood pressure doesn't change when you switch to a high salt diet, there's data from the University of Delaware, Dave Edwards and Bill Farquhar, that your endothelial function, for example, still gets worse. And that might precede increases in blood pressure that might occur later on, if you're thinking about it from a physiological point of view.
Yeah. Does it seem to depend on the person? Like if someone is exercising a lot, does that change even independent of like perspiration?
Yeah, it's a great question. Based on the calculations that I've looked into this before, so typically your sweat concentration of sodium, it varies a ton, but let's just say it's 40 to 50 millimolar. And let's say you're over-consuming your diet at about 100 millimolar, and what that means for people is 100 millimolar of sodium is about 2,300 milligrams, or I believe that's 1 teaspoon. Mm-hmm. And so let's say that you increase your salt intake by that much, and your sodium concentration is 40 to 50 millimole, and let's say that you did happen to sweat for over the course of an hour, and you sweat about a liter, which, unless you're working out in a hot environment, is probably pretty, probably being pretty lenient for that person sweating a lot. Then you need to exercise for an hour with 2 liters of sweat with that sweat sodium concentration to actually fully offset the sodium that you intake. So considering how often most people exercise and how much most people typically sweat, and also the fact that people that are more adapted to heat and adapted to exercise would usually have a lower salt concentration in their sweat because that's just a natural adaptation, then I don't really see that as a fully viable long-term solution. But obviously that is something that probably explains part of the cardioprotective effects of exercise related to a high sodium diet or just any other health factors, for example. And that might be one example of that.
Do you think it's a little bit more important to focus on just like cumulative exposure to salt versus daily intake? I mean, like if one day someone has 4,000 milligrams and another day someone has 1,000 milligrams, so you're looking at kind of over the course of the week, or does like an acute bolus have like increasingly negative impact on blood pressure, or does it kind of wash out if in the following days you're lower? Because I know personally, like I'm all over the map. Like I don't have the same amount of sodium every day.
Yeah, I wouldn't be too worried about one day, really for anything in psychological well-being and anything that will affect relationships. One day or one meal probably won't do too much. We have looked at this systematically, though. At the University of Delaware, we designed some studies that looked at just that. So if you give somebody a meal that's very low caloric, really just as a vessel to increase their sodium intake. So if you give somebody a bolus of 1,500 milligrams of sodium, which is pretty high because that times 3 meals a day plus snacks would be 4, 5, 6,000 milligrams, depending on the person. And we did submaximal exercise, maximal exercise, endothelial function, cerebral blood flow, and we really could not find anything that was detrimental in the context of a single meal, in the context of a young, healthy adult. There are some data in older adults or middle-aged adults, I don't recall the exact population, but they did find some negative effects of a single meal, but we weren't able to reproduce those findings. But again, it could be that we had a generally very young and healthy group. But I think for most of the salt feeding studies that have been done, they typically go on for at least 5 days and more typically in the 7 to 10 day range. So that tells me that even if you were to go on like a 3-day cruise or something, obviously I think you should always try to be mindful of the things you're doing, but I wouldn't expect your blood pressure trajectory over the course of your life to be decided too much by a weekend of high salt food.
Yeah. Have you seen any of these studies that maybe have equated for like insulin levels as well? Because, like for example, in the low carb space, if you're obviously going to low insulin levels, you're going to excrete a lot more sodium. So your sodium intake might be a little bit higher. Have you seen any work that's factoring that into the equation?
Yeah, surprisingly not. There is a lot of physiological rationale for that to be the case. And what that is insulin resistance being associated with salt intake, and also the counter being more salt intake, specifically sodium, being associated with insulin resistance. But a lot of that is derived from cell culture studies, animal studies, or sort of indirect evidence from human studies. Yeah. So that is an open area that our lab might be interested in working in the future. But it certainly is viable. And as you mentioned, lower insulin, more sodium excretion. And on the flip side of that, if you're insulin resistant or you're having a lot of health habits that are not promoting insulin sensitivity, then that could contribute to sodium reabsorption in the body. And there's some data from, I believe, the University of, it's Vanderbilt University, and they've done studies for looking at what happens to when you have too much sodium, because obviously the blood very tightly regulates sodium in the blood, about 140 millimole, and the range is usually within a few percentage points, so 135 to 145, and it's pretty atypical to be outside that range if things are going well for you that day. So where's that extra sodium going? And one of the thoughts is that it might be being stored in the skin. And they did some MRI studies, and actually I think they linked higher skin sodium deposition with unfavorable cardiovascular health measures. I don't know those data quite as well, but I think that is still generally true, that it was still less favorable for cardiovascular health markers that they measured with more skin sodium deposition.
That's wild.
Interesting. Yeah.
Dang. Yeah. It's no, that's super intriguing. I mean, because it's like sometimes it would make sense. I mean, it's sometimes maybe this doesn't make sense to other people, but it clicks with me. Like there's days when you sweat and you almost have like lots of like salt on your skin.
Right.
And then there's days where like equally intense exercise and you don't have that. And I've often thought about that. I've never put much thought into it. I've just wondered, I'm like, how come I'm like so salty today? My sweat is actually gritty. And I wonder if that has to do with like salt being stored in the skin or something. That's pretty wild.
Yeah. I wonder if sweating actually offsets that. It just keeps it mobilized at least. So even if you're not losing it all, you're at least sort of moving things along the cascade. So as you're storing it, you're still at least getting rid of the older stuff. So I don't really know as much about that physiology, but that certainly is pretty plausible.
And can the body, like, if you're an avid exerciser, like preemptively store it in the skin because it knows you're going to sweat and push it out? I mean,
yeah. I mean, I've never really thought about it from that standpoint, but I don't know where else I would put extra sodium if I'm trying to maintain the osmotic gradient in every cell in my body. I guess that's the most readily available site to get rid of it if you're not going to get rid of it in the urine. So yeah, that actually makes a lot of sense.
What about just excess adipose tissue in general, like independent of other things? Because I think we all have probably encountered those people. Like I know plenty of overweight people that have really solid blood pressure. In fact, really good blood pressure. And just like I know thin people with very little fat that have high blood pressure. So is there much correlation between particularly central adiposity and blood pressure?
There is specific to that. So things like the waist to hip ratio. So this is something that people can do at home. You can buy a Gulick tape measure, Gulick. It's a special tape measure they use for, but really any tape measure would work. You measure the largest part of your around your glutes, and then the skinniest part just a little bit above your belly button. And that ratio is actually the strongest independent predictor of mortality and related to body composition. And part of that might be because of the central adiposity relative to the body size. And there's some studies that have even linked with things like things that control blood pressure regulation, like bioreflex function. Those things are specifically worse in people with more central adiposity relative to people with the same amount of adiposity, but in the subcutaneous tissue. So that's just one example. Recently, The Lancet just published this really large consensus document talking about obesity, and the idea being preclinical and clinical obesity. So that is someone, let's say they surpass a body mass index of 30, which is a very common definition for obesity. If you have two people who are both above 30 for body mass index, the person without any other obesity-related health detriments would be considered preclinical obesity. And clinical obesity is that the manifestations or tissue dysfunction might be related to obesity are present. And that's sort of the dichotomy that they're trying to build, because there's obviously a lot more to it, as you're familiar with body composition. And I think there also is something related to the length of time. And as far as, if you maintain a healthy body weight for a long time and then you gain a lot of weight in a year or two, maybe some of those things that have occurred, or not enough time has passed for things to occur to cause sort of irreversible damage or just detriment to other tissues and organs. But if you've maintained a body mass index that would be considered in the obesity category for years to decades, that's probably more time for those things to cause dysfunction with the milieu of inflammation and other things that are related to excess adiposity.
Yeah, that would make sense. What about with resistance training? It's kind of funny because when you look at resistance training, I remember when I was like a kid, when I was like 12 and I was just starting to lift some weights. I remember my grandma, I remember this vividly, her just like telling me like, you're going to increase your blood pressure. Like, it's like, it's just really random. And when you think about resistance training, you think about it, that's like going to increase blood pressure. Yes, while you're actually lifting. But is there any evidence to support like the angiogenesis, the new capillary formation that you might get from doing more resistance training? I mean, is it going to ultimately support lowering blood pressure, or is it really mainly looking at cardiovascular exercise for blood pressure?
So I think that the meta-analysis I mentioned earlier, I think the resistance training alone, dynamic resistance training specifically, I think it had comparable or slightly lower or slightly less of a reduction in blood pressure. So that is on the range of 2, 3, or 4 millimeters of mercury for systolic, for people without hypertension, then a little bit more for with. But what's really interesting is for people that did combined training aerobic and resistance, there wasn't really an additive benefit. It was only a slight. So you would think that -5 and -5 put together would be -10, but it was more like -6 between the two groups.
Were they coming from sedentary, or were they already somewhat active individuals?
It was a meta-analysis, so it was probably a compilation of dozens of studies, and I don't really know offhand. I don't remember them mentioning that in the methods per se, but it could just be sort of the threshold, the same way that if you reduce your sodium intake, increase your potassium intake, if you're starting at a blood pressure of 120, doing all these 10 things is obviously not going to lower your systolic blood pressure to 70, even though on an average level from a cohort, it's going to reduce it by, let's say, 5, 5, 6, 6, 7, 7 between each intervention alone, because there is this homeostatic thing at play for the body to regulate it.
What about blood glucose levels? I mean, there's obviously high levels of glucose can start to damage the endothelium as well. Do you notice much of a correlation there, or is it less significant than some of these other things we've talked about?
It is relevant. So hyperglycemia is linked to, as you mentioned, things related to inflammation and vascular dysfunction. Actually, one thing that's emerging right now in the literature seems to be this triglyceride glucose and waist circumference index, which are sort of all components of a metabolic syndrome, but they're thinking that index might be a very readily available way to basically assess risk in somebody with a simple finger prick or venous blood draw to get triglycerides and glucose, and then waist circumference is pretty easy to measure with a tape measure. Yeah. So it is pretty important that people are thinking about.
What about, and this might get into the weeds a little bit, the world of lip peroxidation, like having these high levels of oxidated fats. I mean, can that impact the endothelium? Like, again, I don't want to necessarily get in the weeds of the seed oil discussion, so to speak, but when you're talking about full-blown oxidation, any literature there?
Yeah, so this is not my area of expertise, but broadly speaking, more oxidative stress that's not properly buffered will cause unfavorable changes to vascular function. There's a researcher, Bob Hickner, at Florida State University. He's working with Mike Ormsby, who I know you had on, and they're doing work to look at how those things are being regulated at the skeletal muscle level and how that influences the way blood flow is regulated. So obviously there's vascular components there in the muscle, and they're actually completing an exercise training study to see if some of those things that might be non-favorable or unoptimal in postmenopausal females with obesity might get benefit from exercise training. So they're looking into that.
You mentioned low-fat dairy early on. Mm-hmm. Was the potential reason for the low-fat dairy just because it's a low-fat source of protein, or was it the actual, is there an actual additive benefit of dairy itself, just so long as it's relatively low-fat?
Yeah, I'm really not sure. If I had to speculate, I'd say it's probably a mix of all of those things. So that is getting more protein, which will cause you to feel fuller sooner. And as you know, fat has more calories per gram. So if you're trying to reduce your calorie intake, so having excess calorie intake is probably not going to be favorable for a lot of these cardiovascular health metrics. So I think some of those things together. And there is some data suggesting that dairy intake, even independent of low-fat dairy, it does have some benefit to vascular health. There's a little bit of probably debate in that literature, so I'm not sure that I would really be able to strongly support it one way or the other, but there is data existing where they've had people consume like cheese, for example, and having high sodium cheese was beneficial for vascular health relative to having high sodium without cheese, for example, with dairy. So there's some compounds in dairy that might be related to it.
It could be a CLA thing or something like that. There's some cardiovascular benefits with CLA, so it could have something to do with there. But the stuff on dairy, it's pretty much split evenly. You can find something.
Same with eggs. Yeah. There's a few hot topics where it's about 50% benefit, 50% impairment. But the thing is, most people consume all those things all the time. So just like anything else in moderation, probably.
So if we just kind of close this whole loop, kind of coming back to sort of the breathing thing. I would say from this discussion, the biggest takeaway that I would get is that probably the almost literal biggest thing that you can do to change your blood pressure is work on your breathing. That's pretty wild.
Potentially. If you think about the costs associated with things, so there's obviously financial cost, there's time cost, and there's energy. So, if you do some task and that drains your body battery by 10% versus there's another task that you like doing, I think for optimizing all those things, I personally use the Inspiratory muscle trainer. They have a manual one that's a little bit cheaper from Power Breathe. That's in the range of $50 to $100, unlike the digital one that's sitting here. And so with 5 to 10 minutes per day and getting the blood pressure reduction that's pretty much on par with any other non-pharmacological changes, then that's probably the way to go. That'd be my preferred if I could only choose one.
Yeah, it's a heck of a, not that I'm saying people shouldn't go out and do intense exercise, but if I could say go do a walk on an inclined treadmill for 45 minutes while I'm also able to field some emails or something like that, and then get this breathing work done with a power breather. Not that I'd want to do that every day, but that seems like a fairly nice trade-off.
Yeah, I think so.
Well, Dr. Watso, where can everyone find you, man?
Yeah, caplaboratory.com, CAP Laboratory. We have information there about the research that we have ongoing, funded clinical trials, and testing services and other lay articles. When we see cool science, we try to share it with people with actionable takeaways.
Cool. Thanks, man.
Thanks.